We're going to get started. Our speaker today is Dr. Chetwan Asanason. He will be speaking on the novel Therapies, Hemophilia A. Our program is underwritten by an educational grant from the Friends Foundation, and a disclosure statement has been signed and on file in the Graduate Medical Office. Dr. Asanason has received his medical degree from St. George University School of Medicine in Bayshore, New York. He went to complete a pediatric residency at the University of Florida College of Health Medicine Health Science Center in Jacksonville, Florida, followed by a pediatric hemo fellowship at the University of Texas Southwestern Medical Center in Dallas, Texas. He currently is a board-certified pediatric hematologist-oncologist at the Children's Cancer Research Institute in San Antonio, Texas. So please welcome Dr. Asanason.
So yes, my name is really long. Everybody just calls me Chad or Chad. They're happy days. I'm a pediatric hematologist-oncologist. We have a hemophilia treatment center at the University of Texas in San Antonio. And a hemophilia treatment center is actually a multidisciplinary combined program consisting of physical therapists, psychologists, geneticists, including the pediatric hematologist as well as adult oncology. At the UT and San Antonio, we take care of about 500 active hemophilia patients, 50-50 adult versus pediatrics. So today what I'm going to talk about is some of the interesting changes actually in the treatment of hemophilia A. And I'm glad to see a lot of students because it's actually going to be a fair amount of physiology. So, as was mentioned earlier, this talk was underwritten by a grant from the Friends Foundation. And the steering committee included Ellis Neufeld from Dana-Farber as well as Dr. Kressler from Georgetown. And there's this disclosure policy, as was mentioned, as well as other staff disclosures. So some of the learning objectives, obviously, are that we're going to look at some of the pharmacologic properties together with the efficacy and safety data of some of the newly available hemophilia A therapies and apply some of that because in this day and age, we actually are using more modified personalized medicine techniques to modify therapeutic management. So a little bit of background on hemophilia. We all heard about the recognition of hemophilia in history, but actually it wasn't until the 1800s where people kind of figured out that it was something in the blood, and that was by Dr. Otto there. And then Dr. Lane actually was successfully able to provide a whole blood transfusion to actually improve some of the symptoms. Dr. Wright noticed that the clotting time was actually prolonged, so we actually had a measure now in the late 1800s. And then we were actually able to kind of define that further in the 1900s as well as into the 1960s, where we actually are able to identify Cryoprecipitate. And this is a pool who in 1964 identified that factor in Cryoprecipitate, which actually provided about 8 units of factor 8 per milliliter. And then we were actually able to measure factor 8 and allow it to be treated to approach about 30%, which actually is that number to be able to kind of move somebody up into a less of a risk for bleeding complications. They did notice that when they provided this Cryoprecipitate, the bleeding stopped more quickly. And now you actually have a management option that every blood bank could offer. And obviously, the lifespan of these patients did increase. So what happened after the 60s? Well, there are a few in the room that remember the concerns that developed with plasma-derived products and all plasma-derived products in the era of HIV. It was actually, however, in the 60s that we identified hepatitis B, which continues to be a little bit more of a problem than HIV nowadays. We look at plasma-derived products in the early 70s, which have been treated later on in the mid-80s, and now we are actually able to provide not only recombinant-based factor, but I'm going to show you some data today that kind of suggests that this humanized factor actually may be better for the patients, especially pediatric patients. So a little bit more background, epidemiology. Factor VIII deficiency, 1 in 5,000 male births. In the United States, we go to about 20,000 patients. Factor IX deficiency is about 5 times less common. Clinically, you'll see more bleeds that are associated with muscle bleeds, joint bleeds. These can be major or minor. In hematology, it's very easy to kind of differentiate a little bit based on clinical presentation. So if you have a patient that has petechiae or other platelet type bleeding, this is different than what we would consider coagulopathies like factor VIII deficiency, factor IX deficiency, which kind of ooze and develop these hematomas, muscle bleeds, etc. You can have significant complications. As I mentioned earlier, the hepatitis and infectious issues that we identified in the 80s. But you can also have inhibitors where the body develops antibodies specifically to that clotting factor replacement. And this can occur in up to a third of patients. And the problem with this is that once you develop this antibody, it's very difficult at times to overcome. So then you are stuck with a patient who has significant bleeding, and you don't really have options or very many options to treat them. So people have looked at different aspects of treatment. One aspect is prophylaxis, so we just give them the factor to help them prevent bleeds from now on. Turns out that prophylaxis does very well. However, you have to get over a certain window period where you are at high risk of developing these inhibitors, because you certainly don't want to develop an inhibitor in early childhood and then continue to have problems later in adulthood. And then, as you may or may not know, factor is very expensive, anywhere from $1,000 per 1 unit to higher than that, actually, for some of the newer replacement therapies or even some of the bypass therapies. But we do have options. Some new things that are coming down the pike that I'm going to talk about are extended half-life factor replacements. Gene therapy is actually making strides. And then there's actually things that we use that are non-factor therapies. We're going to bypass the coagulation system altogether and look at how to inhibit it. So these are just some cases that, as we kind of go through this, I wanted you to kind of think about. We're not going to necessarily answer these questions, but these are some of the presentations. So the first one is a 25-year-old with hemophilia. We know he has hemophilia. Started prophylaxis back in '96, which is provided at twice weekly, factor VIII. On this regimen, he rarely bleeds. However, when he does, it's usually related to trauma. For example, if he twisted an ankle or something like that. It is right angle, actually, a history of being a target joint. A target joint is a joint where you get damage and the hematoma formed within that joint actually causes more of an inflammatory reaction. So the synovium actually becomes very friable and very kind of brittle. So you have a higher risk of bleeding into that same joint. And it's just a vicious cycle. It gets worse and worse and worse. However, Jonathan is actually an avid swimmer and cyclist, so it behooves us to try to keep him under control. He's currently on very traditional recombinant factor VIII, and that's what the little R stands for. And the PK levels show a half-life of about 14 hours. And you'll see why that becomes an issue later down the road. So some clinical choices based off this scenario, would you switch into a longer-acting drug? And then what dose schedule would you use? Now, he also has a grandfather. Maternal grandfather has hemophilia A. His grandfather was actually sedentary. He's got end-stage joint disease. It's frozen solid. He's got a BMI of about 35. He's in an assisted care community and currently is on prophylaxis with recombinant factor VIII. However, the clinical scenario is that he actually suffers from intermittent AFib. So how do you handle AFib in setting hemophilia? And adjust recombinant factor VIII based on body weight or as ideal weight? And would you actually switch to a long-acting factor VIII in this scenario as well? And I'm a pediatrician, so I had to throw a pediatric case in there. This is a 5-year-old of Jonathan's older sister. This 5-year-old was switched at age 4 from recombinant factor VIII to the enhanced lifespan factor VIII. His bleeding has been reduced since the switch, and the PK went from 7 hours for the recombinant to now it's 10 hours. Lab testing, however, reveals lower factor levels at the past 2 visits, and the question is, why was this factor level reduced? All right, so let's kind of think about some of the scenarios as we kind of go through some of these slides coming up. So in hemophilia A, you can actually have basically 3 types of severity. You could have no factor level, less than 1%, and that's severe. In severe patients, you'll have spontaneous bleeding, intracranial bleeding. They have a high propensity of developing inhibitors. This may be related to the amount of factor that they're actually exposed to, but also there's some concerns that maybe some of the mutations are a little bit more predisposed to developing these inhibitors. On the other side of the spectrum, you can have mild. And you don't really have to have a lot of factor to be able to kind of control bleeding. Mild patients have anywhere between 5% to 40%. They generally tend to have bleeding more from significant trauma or surgery. They tend not to have as many inhibitors develop. And then you have those in between, 2 to 5% for moderates. They have fewer spontaneous bleeds, but the bleedings are bad and severe when they do occur. They don't necessarily have significant arthropathies, but they still can have some joint bleeds. An adults versus pediatric patient, you have some different considerations for management and complications. Children tend to have a higher risk of inhibitors. They tend to have more exposures. They tend to have more exposures to different infectious agents, so their immune systems are really hyper-revved up. Their PK tends to be a little different, and it varies almost individually, and which kind of begs the question, we dose pediatric medications primarily based off kilogram, and that's the best we got, but the PK dosing is significantly different and can vary widely. We see that some as well when we do some PK dosing for our chemotherapy agents as well. Children have a difficult time with adherence. It's hard to kind of get a little 2-year-old to sit down and put an IV in. We tend to have to use ports sometimes with either home health or teaching the family to use the ports. Ultimately, as they get older, we hope that they can self-infuse as well. And the activity of a young child is really hard to control. Now in adults, there's a different set of problems. They're still old enough to have been exposed in the 90s where infectious issues were really prevalent. And then when you talk about switching their prior treatment, the concern for whether or not it's been working very well or related to any kind of significant complications, and they also have a significant issue with adherence. They don't have a bleed, they don't necessarily have the funds to make sure that they are staying on prophylaxis, many different issues. So this is a list of the current factor VIII products that are currently available. They're molecular structures or molecular components. There are many more than these. They're different names, but these are a few of the more common ones. There's alphanate, which which is plasma-derived. Plasma-derived versus recombinant basically means the recombinant is actually formed in a petri dish. We hijack different either cell lines like Chinese hamster ovaries or other agents to be able to kind of recombinantly produce these proteins. Plasma-derived actually are derived from plasma donations, plasma products, similar to how we would identify IVIG, things kind of like that stuff. Now, recombinate, coagulate are our first and second generation recombinant. We actually have third and fourth now, Advate and Zinthra. All of those are, well, 3 of those are full-length molecular factor levels. And then Zinth is a little different. It's a kind of a B domain kind of absent, so that theoretically it has less of antigenic activity to develop an inhibitor. So pros and cons. Again, recombinants, there's less, if any, chance of pathogenic transmission, and you'll hear a lot of the factor companies talk about little things between the different recombinant, but ultimately they're all recombinant and really have no true potential for pathogenic transmission. They're manufactured, so it's really easy in case you really have to scale up production to do that. And you can do a lot of biochemical modifications for tweaks here and there. Plasma-derived actually has a pretty good safety track. After the 80s and 90s, where we had a lot of infectious issues, we were able to kind of solve that problem. However, most people today still would rather use recombinant products because of the concern for infection risk. Plasma-derived is significantly less expensive, however, and there's some actual evidence that I'll show you that it may actually induce less inhibitors. So it may be more useful in younger patients where the risk of developing inhibitors is pretty high. So these are just some names. We talked a little bit about this issue of a truncated B domain. And basically it just means that it's a smaller molecule and hopefully would induce a lower inhibitor risk. And then Covaltry is one of these things that you tweak where you say, okay, there's no human or animal-derived raw materials added to the manufacturing process. And this is based off of the concern that any kind of exposure to human or animal-derived proteins or cell structure may kind of put that molecule at higher risk for developing an inhibitor, and really hasn't really panned out to be of any true significance. All right, so I talked about prophylaxis versus episodic therapy. The current recommendations are actually based off of this study by Marilyn Mayco Johnson, published in the New England Journal of Medicine. Internationally, the recommendations are for patients to receive prophylactic therapy. And what she did, she looked at 65 boys with severe disease. She randomized them to receive either prophylactic therapy or episodic therapy, meaning they only received factor when they had a little bit of a bleed. She specifically looked at joints and looked at MRIs of these joints, and there are the results. Patients who were on only episodic developed more issues with regard to their joints, and those on prophylaxis still had pretty normal joints. Overall outcome was that prophylaxis showed an 84% relative risk reduction of joint complications. And remember when I said that if you have a joint bleed, you're at much higher risk for developing more joint bleeds as that joint becomes a target, because that vicious cycle of inflammation, destruction, and then causing further bleeding in that joint. Now, the concern about Dr. Johnson's and now the international recommendations is the cost, and obviously adherence to those recommendations. So there's been a lot of work looking at trying to kind of tweak prophylaxis to the point where you can be less intrusive as far as providing factor on maybe a twice-a-week basis rather than every other day or every day. So this is a curve, an idealized curve actually, where we looked at percent factor levels over time. So it's a PK curve. And each of the aspects of this curve kind of tells us a little something. So that bracket shows the adequate hemostasis range. That actually can help us prevent activity-related leaks. So there's enough factor in that bracket to where we feel comfortable that a patient who's competitive skateboarder or something like that, or soccer player, won't necessarily have a significant risk based off the activity. Now, the area under the curve actually helps us kind of figure out how to prevent subclinical type bleeding. And this area under the curve we look at primarily for less active patients, obviously. And then the trough, again, we don't need quite a lot of factor to kind of make sure spontaneous bleeding doesn't occur. And the trough is actually important when we look at that aspect of treatment. And this is actually what a PK curve tends to look like. It doesn't look as pretty as that idealized version. Obviously, we don't have kind of big points all over the place. You can see that in some instances we only have 3 points. In some instances you really only need 2 points to try to figure out either the area under the curve, the peak, or the trough. So this is a slide showing kind of different activity levels, and you can just kind of in your mind, common sense can understand that patients who have significant amounts of trauma/activity that is associated with trauma, like the sumo wrestler or the linebacker, will have to have a significant higher level of factor within their body to reduce any kind of concerns for trauma-related bleeding. Less traumatic sports like swimming will not necessarily need to have as much of the factor within their system. And then somewhere in between basketball, depending on how much people are checking, will actually need a little bit more. This is just a slide talking about that 2 points replaces that day-long PK. And as you can see, you don't necessarily need all those points if you just need to know either the area under the curve or the trough. But it is fairly critical, and this is one of the key messages in these slides, is that the peaks and troughs really are very important. Area under the curve as well. And you need to match medications to lifestyle. Again, in this day and age of more personalized medicine, these are the criteria by which we actually can adjust treatment regimens and management so that you're not overdosing patients and you're not underdosing to the point where they're putting them at higher risk. And the PK actually is a very good guide to try to figure out this medication switching. Switching in the sense that you may decide to have a longer acting factor product as well. So in these long acting factor products, these are some of the more interesting physiologic kind of tricks that we are looking at right now. So I mentioned the B domain truncation. There's actually a B domain truncation combined with factor VIII Fc fusion. And there's a slide coming up that kind of shows you that these kind of products actually are recycled within the cell and serum to the point where it actually prolongs half-life because of that recycling. Pegylation, where you combine the fracture product with a larger molecule to try to prevent a lot of the metabolism and thus have a higher half-life. And then you have these things where you have single chain factor VIIIs, where the single chain actually it can combine with, is protected by something called von Willebrand's factor to the point where it actually has a longer half-life. So I'm going to show you a couple of slides on these. So this is that recycling component where you have a protein. You can do this with almost any protein. You fuse it to an Fc portion of an antibody. So what that does is it gets endocytosed into the cell, goes through the endosome. However, because it's an Fc portion, it actually causes a recycling of that endosome. And thus that protein is actually released back into the serum. So there's a recycling of it rather than metabolizing it by and degraded into the lysosomes. So this actually allows us to have longer half-lives of certain proteins like factor VIII. And this is kind of a neat little trick that we're using as a lot of protein products. This is a trial showing that with these products actually do work and are actually able to prolong the half-life of these products. We studied this as well in kids to see if there's any development of inhibitors for some reason, whether or not the Fc portion actually somehow triggered the immune system, and that is not the case. No development of inhibitors that was identified. So in pegylation, similar studies, whether or not they actually worked and developed fewer bleeds, and that is the case. And again, they didn't necessarily develop inhibitors as well. Now, this HEC293, this is a protein that's actually expressed in human cells. What happens in these HEC expressions is that they actually hide a little bit because of the way that these proteins are processed. So again, it's they don't get broken down within the lysosomes as quickly, developing longer half-lives. You can see 17 hours there. And again, they didn't develop any inhibitors as well. And the PTPs, previously treated patients. In some of these slides, you may see a PUP or previously untreated patients. That becomes an issue when you're looking at studying these patients, whether or not they've had different exposures before. So this is a cartoon of that single chain, factor VIII. So usually factor VIII is kind of bonded in that left cartoon. You have the A2, A1, and A3 portions kind of side by side. You can actually build this protein where it's covalently bonded in a straight line, and that actually improves the PK because, you don't see it, oh, there it is. When this protein is actually in the serum, it's actually bound as a carrier protein to von Willebrand's factor, and as you can see, the A1, A2, A3, if it was in a straight line, it actually can be kind of encompassed a little bit more by von Willebrand's factors to permit it to hide from destruction and last a little longer. And we actually have some clinical data on that, and that von Willebrand's factor with any product actually can reduce clearance, which is what the graph on the left is showing, long half-life. So these and long half-life, extended half-life proteins, they actually improve PK. The half-life, however, aren't dramatically increased. They tend to be around 1.5 times what we would expect a normal half-life to be. The efficacy is really comparable to the recombinant products, which is what people are kind of standardizing these two. They did not develop any extra inhibitors. Their safety was pretty comparable to the recombinant products without any allergic reactions or development of thrombosis. Again, the risk of if you have an extended half-life, are you actually putting a patient at risk of developing more clots? Problems are that, again, that modest prolongation of factor level is too dramatic and wonder whether the cost is actually worth it. You do get less frequent infusions. You can get less ports and IV sticks and less ER visits, and then fewer interruptions from school or work. And there is a subjective quality of life improvement by the patients as well. So, inhibitors are actually very important and can cause a lot of headaches in hemophilia patients and their providers. So what are the risk factors? So in patients, the severity of hemophilia, as you saw in the previous slide, can be a factor. The type of factor VIII mutation can be a factor. If there's a family history of inhibitors, or I guess you can think about it this way, is there a family history of an overactive immune system that's predisposed to developing kind of extra antibodies? It turns out African American populations are at somewhat higher risk, and there are actually some new polymorphisms in the immune response. And again, thinking about hyperactive immune systems that actually are related to the development of inhibitor formation. Treatment-related factors are actually related to the number of exposure days, the intensity of that exposure. Are you treating somebody and exposing them with one big bolus, or if you're prophylaxing somebody, it's smaller kind of exposure types. The product type is important, and we'll kind of see some of the data from that, or plasma versus recombinant. And the age at first exposure is important because younger children tend to have a higher risk of developing inhibitors than adults. And related to the intensity of exposure, the prophylaxis versus replacement-based therapy. So there's actually a study recently published this year called CIPIT, and it looked at the development of inhibitors and compared actually young children. They were all less than 6. They all had severe hemophilia. They were what we call PUPs, no previously untreated patients. So there's no risk of any kind of other exposures kind of mucking up the data. They also had very limited blood exposures as well. Again, we're talking about trying to minimize the number of exposures to that immune system. So they were actually randomized to either plasma-derived factor VIII product or recombinant factor VIII product. And you can see the numbers there. And this is what they came up with. And this was published in the New England Journal earlier this year. And you can see that there was actually a significant improvement or reduction of inhibitor formation in patients who received plasma-derived product. Now remember, plasma-derived products got a kind of a black eye in the 80s with the advent of concern for all these infectious complications, infection risk with HIV and HPV. So nowadays, these plasma-derived products have not been associated with any infections. So the safety profile is very similar. They're actually also cheaper than the recombinant factor products. And based off this data, they actually may be better in terms of reducing inhibitor formation. Now, we talked a little bit about the pegylation as well. And these are some new factor VIII analogs. And again, the half-lives tend to be extended a little bit, not significant. So there are actually some new approaches that I think are kind of neat that I was going to mention in a couple of slides here. And one's a bispecific antibody. It's actually not a factor VIII product. it's an antibody that stimulates the receptors to think that it's factor VIII. And then we talk about inhibiting the inhibitors, where you actually kind of change the balance of your coagulation system to the point where you don't have any significant risk for bleeding. Now there's a link down there, My Life, Our Future. So, oops, it's coming up in a different slide, but My Life, Our Future is the opportunity for anybody with hemophilia or a bleeding disorder, for that matter, to be able to get genotyped. The advantage of genotyping, so we're trying to understand how some of these mutations affect downstream physiology and downstream phenotypes. We're learning a little bit more about certain genotypes, as you saw in the previous slide, the polymorphisms with respect to the immune system. So it's not necessarily the factor, but it's also some of the immune system polymorphisms that are being looked at. So this is that antibody analog to factor VIII. You can see the receptors there on the left, and it's actually just a bispecific antibody that binds to the factor IX and factor X, if you can remember from your coagulation cascade. But bottom line is that it binds to these receptors and makes the cell and endothelial cell lining think that it's factor VIII, and thus reduce bleeding risk. It was actually studied in a small population of Japanese patients. Seemed to work very well. It was dose dependent, so you could actually dose this thing very easily. You could test it with a PTT, and the factor IX triggered thrombin generation in all patients, and there are really no serious events. They're actually working on right now the extension study for these products. They did look at annualized bleeding risks. That's what ABR stands for, and it was actually able to kind of reduce that risk. Now, Inhibit-the-Inhibitor is kind of interesting. So this is the cascade. We do know that there's some crosstalk between the extrinsic pathway and the feedback loop of the intrinsic pathway. The major advantage of the intrinsic pathway is that amplification and propagation process. So it's like a flywheel spinning, causing all these proteins to develop a clot formation. So what we're doing here is that if you think about hemophilia in terms of balance, and all this stuff happens in this plasma, so it's like soup, it's like cooking. You have too much salt, or too little salt, and that's in the sense of hemophilia, where your clotting-based proteins are a little less, and your anticoagulate-based proteins are a little higher in relation. In factor replacement, which is the traditional treatment, you're adding more salt to kind of even out the taste. What we're doing right now is considering, well, what if you take out some of the anticoagulant proteins or inhibit them to the point where you get back into balance? You don't necessarily need a quantity of factor, you just need to develop that balance. And that's what we're looking at in terms of the couple of these products. And this is an anti-tissue factor inhibitor protein. It tends to have a decent plasma half-life. It has high selectivity, and it seems to work fairly well, because when we look at another factor, this is an antithrombin 3 inhibitor, you can actually see some of the, again, the ABR, annualized bleeding risk, being lowered based on the dose-dependent curve. These are very new things come out now, this year, actually last year, and they're very promising. So we may be able to kind of change the way we really think of clotting, and this will affect, again, how we think about clotting in many instances: trauma, surgery, medicine when we're talking about anticoagulation for different related diseases and bleeding risks and clotting risks. Now, ultimately, people have always said gene therapy is the way to go. And they're working on it, primarily with adenosine-associated viruses. 3 clinical trials, and actually Hemophilia B actually shows some clinical efficacy. Hemophilia A is recruiting, and it seems to have somewhat of a decent duration, and that's the issues that we're trying to make sure that the transfection lasts. And there's actually a product right now in preclinical phase. And our hemophilia prevention trials are out there. Inhibitor response trials are out there to kind of reduce tolerance to inhibitor production. So once you develop an inhibitor, it's kind of like allergy-based therapy. You give them little bits of exposure to the point where you hope you're in developing a tolerance to the antigen. This is a slide based on My Life, Our Future, as well as some kind of last summary slides. So the role of non-neutralizing antibodies, we don't know, and more than likely we don't think they really do much. And when they're talking about non-neutralizing, we're talking about antibodies against some of the proteins in the product, either whether they're proteins in the humanized portion or a protein to the against the active site. And the question is that really kind of causing an effect? Well, we don't necessarily think so, based off some of the early data, but there's a concern. The new products are very new. What is the long-term efficacy and safety? Are we going to end up developing different types of inhibitors or complications? And then as we modify some of these things in relation to the immune system, is it really going to affect the immune system in bad ways? Now, one interesting question is, can we reduce tolerance through use of these long-acting factors? Again, tolerance, the theory is that you provide low-dose exposure. Could you do this with just one little injection rather than putting a child through allergy therapy? We really don't have patient registry, which is hopefully why this My Life, Our Future can actually assist us in developing a more robust patient registry. And do we really have biomarkers? Not really. We basically are measuring factor levels, and that's all we're measuring. Standard of care is good right now, but it can be difficult at times. Insurance and formulary goals, again, the cost is astronomical for these patients. We're talking about factor replacement, again, about 1,000 or more a unit, which can get very costly, not only in an individualized setting, but also in a public health setting. One size doesn't fit all, and again, more personalized PK-based management is more effective. And we need kind of more outcomes for adult populations. A lot of the studies have looked at young adults and kids, and again, because of that concern for inhibitor formation. Comorbidities can complicate treatment. So that back to that case with regard to anticoagulation for AFib. So AFib, your concern actually is more of a platelet-based issue, not necessarily the coagulation cascade-based issue. So there's actually a score that you can combine with your PK studies to try to alleviate and minimize that risk, and whether or not you're going to combine aspirin, which is an antiplatelet medication, with some of the anticoagulation base. Not all bleeding damage is usually evident. Sometimes it can be internally. You don't necessarily see it until it gets really big. We're not really good at assessing bleeds. Patients, we have patients, I'm from South Texas, so we have patients even further south in what we call the Texas Valley, where they just kind of let things go forever, and then when they get back to the hospital, they finally they show up with a bleeding. That joint is really a mess and can cause just kind of more permanent damage. Therapy, again, is very costly, not only for patients here in the United States, but we actually have a twinning program where we do a lot of global work in our division. And the third world health systems are really getting slammed by a lot of these costs. We talk about personalized approach. We talk about the activity level. We talk about getting PKs. We want to make sure you understand the age and those risks inherent to the age, and then think about the adherence, specifically talking to the family. What can they actually do? Is this a family that could do 3-4 times a week factor, or is this a family where you really want to try a product or a treatment regimen where to minimize those infusions? And then once you get a target joint, you may not be able to kind of reverse it. So you want to try to prevent it as much as you can. This is a little cartoon again on individualization. And this is the conclusion. Patients have individual PK profiles, not only for factor VIII, but for almost any medication that you can think of as you're kind of going through your training. Innovative strategies for factor VIII replacement have been okay. It's extended some of the half-life and reduced inhibitor development. We do want to treat to a target trough as far as prophylaxis to prevent kind of spontaneous or subclinical bleeds. But again, when you think about the activity level of your patient, you need to kind of take that into account. They may need to stay at a higher level. Lab results can be variable, so you want to be careful about looking at factor levels between multiple different labs. They may not be comparable. And then we do have experimental approaches that go beyond just replacement therapy, and hopefully these approaches will kind of take hold and become available more in the clinical regimen, clinical work where it becomes a little easier to provide. And I believe that is it. So I'm just going to leave that slide up. So we have a few minutes. I can answer any questions. Again, I'm a pediatric hematologist oncologist, but we do take care of adult patients as well. So thank you again for having me. I look forward to kind of taking a look around town. And again, thanks again.